University of New York.
Hello, welcome. It's a nice packed house today. Wonderful. Okay, I'm going to talk to you about lichen planopilaris and frontal fibrosing alopecia. These are my disclosures. So let's talk about lichen planopilaris. In terms of clinical history and evaluation, it's mostly in adults, but we do see it in children. The onset is gradual. The symptoms are lots of itching. That can be an early sign. There may be pain and burning. And there can be hair shedding, which is variable. And the pull test is frequently positive. It may not be always, but frequently it is. And so this is the kind of patient we see who may have lichen planopilaris in our offices. And so how do we approach somebody like this? My practice is all hair. I don't do anything else. And I'd say at least half my patients have cicatricial alopecia, and most of them have lichen planopilaris. So I see at least 5 or 6 of these every day that come in. And we also can see it in a little bit of, we had a talk today on pseudopelade of Brock, and this might be the footprints in the snow, but I myself looked at papers from 1895 from the Pasteur Institute, Brock's papers, and it really describes, he did see some scale, he did see some inflammation. It wasn't totally non-inflammatory, and I think a lot of what we think is pseudopelade of Brock is actually lichen planopilaris, though it's controversial. This is a typical case of a middle-aged woman who has lichen planopilaris. The vertex of the scalp has it. It spreads, and it's inflamed at the edges, and we use trichoscopy to really look how inflamed it is, and we'll talk about that. This is another typical case. We see this day in and day out, just one after another, and they come from all over the world to come to see me, and so we just see one case after another of these kinds of cases. And when we look at it under the microscope, trichoscopy, we see loss of follicular ostia, we see perifollicular scaling, and we may also pigment incontinence or blue-gray dots. So when we look at it, we always look at it, and in our office at NYU, we have a 52-inch screen. So I take the photo finder, I put it right on the patient's scalp, and I show them what it looks like on a 52-inch screen, so they see what I see, rather than just take a trichoscopy or dermoscopy, and I look at it, which most offices do. We want the patient to look at it. We want the patient to see all the scaling. And so every time they come in, they say, well, is there scaling? Is there redness? What's going on? And when you have a huge screen showing them this, it really kind of really gives them an idea of how inflamed they may be. So how do I treat this? Okay, we talked about diagnosis, but what do we do? I mean, we need a plan of action. We need to have some idea of how to approach patients like this. Well, disease activity is determined by the symptoms. Is there itch? Is there burning? Is there pain? Trichoscopy, perifollicular hyperkeratosis and erythema, which I show every patient, and we go through it. And of course, we do the pull test and see if it's positive. And so this is the kind of algorithm that we use on every patient, and I go through it with every patient. We publish this extensively. You might want to take a picture of it. When somebody has a classic lichen planopilaris, if it's rapidly progressive, we may use oral prednisone simply for 8 weeks, 40 milligrams a day, tapered over 8 weeks. You taper by 5 milligrams per week. Then, but if it's not rapidly progressive and it's slow, which it usually is, we divide patients into less than 10% scalp involvement or more than 10%. If it's less than 10% scalp involvement, we'll use intralesional triamcinolone acetonide, and we will use 10 milligrams per cc, and we'll use 2 cc, so a total of 20 milligrams, which you're allowed to do once a month. I've spoken to endocrinologists. it's fine. You can give somebody 20 milligrams a month, not more than that. And so we'll try to spread 20 injections of 0.1 cc each all over the scalp, wherever they have the problem. We'll also add, and this was my invention, a combination of tacrolimus, clobetasol, and minoxidil used as well on the patient, in addition to the injection. So we use a topical and the intralesional. And I'll just show you a picture of how we inject. And here you can see how deep we go into the area. Each time we inject, it's 0.1 cc, and it's 10 milligrams per cc, 2 cc's total. So you're only doing 20 milligrams per month, which you are allowed to use. Now, we also looked at other things. Many of us use doxycycline in our practice, and we recently published this article on the efficacy and tolerability of low-dose versus high-dose doxycycline in the management of scarring alopecia. We published this past year, and we found that 20 milligrams twice a day is just as good as 100 milligrams twice a day. 100 milligrams twice a day is the antimicrobial dose. You don't need an antimicrobial here. You want an anti-inflammatory. And that's all you need, is 20 milligrams twice a day or 40 milligrams a day. And that usually will control the problem if you're going to use doxycycline. And so we did this study. We had a low-dose group. We had a high-dose group. We compared it. We had over 248 patients. And we showed that 20 milligrams twice a day is just as good as 100 milligrams twice a day. And so we've now reduced our, for years I was using 100 milligrams twice a day. We don't anymore, okay? It causes so much upset stomach and all sorts of other problems, increased sensitivity, and so 20 milligrams twice a day usually can do the trick. And what about naltrexone is another systemic agent we use. And I was one of the first in the world to use naltrexone for lichen planopilaris. It is an anti-inflammatory. We use it at 3 milligrams per day for the treatment of lichen planopilaris. Reduces the symptoms of itch, burning, and hurting. The side effects at low dose are generally mild and include vivid dreams, nightmares, headache, and increased anxiety. And so this is an anti-opioid. You have to warn the patient that it's not an opioid, it's an anti-opioid, so it's fine. And we're not using high doses. We use usually 3 to 4.5 milligrams a day, and it really takes away a lot of the itch, burning, and hurting. And what about pioglitazone used? We find that is a PPAR gamma agonist. PPAR gamma is a pathway that it makes the sebaceous material around the hair follicle more normal. And we know that that when the sebaceous glands are destroyed, as in the Asebia mouse, that's a mouse that has no sebaceous glands, you get cicatricial alopecia in the mouse. And so we feel that normalizing cholesterol synthesis within the sebaceous gland will allow the creation of a more functional hair shaft. We've used it at 15 to 30 milligrams a day, and we showed that it did work. So it's something else that we can try in our armamentarium. And so another thing to use, and we'll go through this in our algorithm, is the excimer laser. The excimer laser, 308 nanometers. This is not the red light lasers. This is something they come to the office for. They could also buy it over on Amazon as well, but we prefer they come to our office. We control the dose, and we hardly ever go more than 900 millijoules per treatment, and they come twice a week. The problem in the United States, the insurance companies don't want to pay for it, and so patients have to pay out of pocket, and it can be quite costly. They're coming twice a week. However, if we write enough letters, the insurance company will pay for it. So you should know about using these lasers, particularly the 308 nanometer laser. What about platelet-rich plasma in scarring alopecia? I feel that for most people it does not work. However, other colleagues of mine feel it does work. I was just at a conference recently, and I was told, this was in Austin, Texas, she said she uses all the time on her frontal fibrosing alopecia, and it works. I don't really think it, I've used it on frontal fibrosing. I don't think it does much. But some people think that it works. But we published this paper to show it doesn't make people worse, because we were scared that maybe, these injections and injecting PRP with these growth factors might actually make people worse and cause more inflammation, but it doesn't. So we were the first to show it didn't make people worse. It may have helped a few people, but it really doesn't work that well in cicatricial alopecia. So let's get back to our algorithm. We talked about less than 10% scalp involvement. If it stabilizes, we'll continue with our injections, and we will continue as necessary. If you have more than 10% scalp involvement, have to go over to the other side. We use 10 milligrams per cc, again monthly. We also use tacrolimus, clobetasol, and minoxidil twice a day. And we'll also use doxycycline, 20 milligrams twice a day, which I just discussed. And of course, we may use also hydroxychloroquine, 200 milligrams BID. As soon as you tell the patient that it may cause eye problems, it turns them off. However, it is a safe medication as long as they are ophthalmologically monitored. In the United States, they need to be monitored every 6 months. In Canada, where I used to practice, was once a year. Their retinas need to be examined and made sure there are no problems, because if there are problems, they are irreversible. They will not go away. And sometimes they can continue even after you've stopped. So you have to be careful with hydroxychloroquine, but it actually works quite well. So that's another option if the patient is willing to go on it. And then if it doesn't seem to work, consider your pioglitazone, which we talked about, 15 milligrams per day, or naltrexone, 3 milligrams per day. Now, if all these things don't work, then there's the, again, excimer laser, mycophenolate mofetil, methotrexate, which actually does work quite well. Sometimes old treatments from 30, 40 years ago work on these kinds of things. Cyclosporin, low-dose isotretinoin, and JAK inhibitors we're now using more and more. I like upadacitinib quite a bit now, starting out at 15 milligrams per day, going up to 30 milligrams per day, and I find that it works. The problem is getting the insurance to pay for it. They will only pay for other diseases. They don't want to pay for LPP, and so we have a problem getting it. But the ones that I've used it on, that drug actually does work. So getting a JAK inhibitor, if you can't get that one, try other JAK inhibitors, but I feel that JAK inhibitors may have a big role to play in scarring alopecias. What about frontal fibrosing alopecia? There are guidelines that were spearheaded by Elise Olson that you may want to look at in the British Journal of Dermatology, how we examine each patient. We usually use the outer canthus as a way, a fixed point on the face. Then we then go up and we kind of measure where the hairline is, I guess. Okay, and so for frontal fibrosing alopecia, we've looked at 62 patients. And we showed eyebrow involvement in 96%, symptoms 14%, autoimmune disease 11%. And in terms of the history, it's usually older adults, onset is gradual, symptoms rarely associated with itch, burn, or pain, hair shedding variable, pull test positive on edges of affected areas during the active phase. And this is the kind of patients we see. We're all familiar with this, with frontal fibrosing alopecia. This is typical cases, and we see this day in and day out, nonstop. The eyebrows are frequently involved, as I said, and we take pictures of everybody. We take pictures of their eyebrows and side views and front views as well. And then this is not from me. This is from Rodrigo Permez, who did an excellent picture of the papules that you sometimes get when somebody has facial papules associated with FFA. And we'll talk about how we treat that. I take various measurements, as you can see here. So we take 5 measurements from the outer canthus straight up, glabella, hairline, and sideburns as well. And we record everything on every patient that comes in. Of Of course, we do a trichoscopy. We see perifollicular hyperkeratosis, erythema, loss of follicular ostia, and some of them show pili-torti as well at the base of the hair follicle. And so what is the treatment? This is 62 patients we looked at, and we did a retrospective analysis, and basically I've already gone over this slide. It's there twice, but I show patients this. This is from our NYU patients, showing that 90% that we can help a lot of people with it, but not everybody, 70%. And this is the algorithm that I think you should, you may want to take a picture of. If it's less than 1 centimeter of hairline recession, we'll use our tacrolimus, clobetasol, minoxidil. We'll use intralesional corticosteroid, but only 2.5 milligrams per cc. If there is if their hairline recession is more than 1 centimeter, then we will use 5-alpha reductase inhibitor. No improvement, consider hydroxychloroquine, doxycycline, 20 milligrams twice a day. We don't use 100 anymore. Pioglitazone, 15 milligrams per day, or naltrexone. Other options would be mycophenolate mofetil, methotrexate, cyclosporin, oral retinoids, excimer lasers, even on the eyebrow area. Again, JAK inhibitors may work in this condition, and I don't think platelet-rich plasma really works that well. And this is what we can use, the tacrolimus, clobetasol, minoxidil. Now we can put them all in one solution. Our pharmacist figured it out, and we can use that once or twice a day. And this is how we inject. We go from ear to ear, 3 cc's total into the area. At 3 cc's basically from ear to ear, 0.1 cc each. This is the depth that we use. And we have to be careful, though, whenever we do cortisone injections near the eyes. We have already had a few cases of having liquid forming underneath the retina. So if a patient has problems, think of central serous chorioretinopathy if they start having eye problems. The ophthalmologists know all about this. You may need to stop the amount of corticosteroid injections you use around the eyes. So this is our algorithm that I've gone over. And how do we get rid of the papules? This was by Rodrigo Permez. He used oral isotretinoin, 40 milligrams per day, and then tapered it down. And that seemed to take care of the facial papules. And I'm using now more and more of the JAK inhibitors. There's topical duroxolidinib, and now there's Abzugo we also use as well, and that may help a lot of people. So here's the topical ruxolitinib. We have already published this. And so this was actually, it was... this shows that it may work for chronic hand eczema. It does work. It's already approved, but now we use it now for scarring alopecia, and it has been shown to help. And then dutasteride has also been used, and also consider associated products that may make it worse. There are certain sunscreens. The chemical sunscreens may make it worse, and also you may want to do some patch testing on these individuals. Certain limonene and linalool may make it worse. And so we avoid avobenzone, oxybenzone, Galex fragrance mix as well. Use mineral-based products, usually zinc oxide. So this is the algorithm. You might want to photograph it just to give you some idea of how we treat frontal fibrosing. I don't recommend hair transplants on these people myself because I've seen it get worse. I've seen it start from a hair transplant, so I really have issues with surgery. I tell people to avoid brow lifts as well, or any kind of facelift around the face. So that's our book, and I thank you very much. I thank our team. We have quite a big team of people who work with us. And I thank you very much. Okay, our next speaker, we're so lucky to have somebody from Morocco, Professor Awatif Khalati, who will talk about dissecting cellulitis, she will talk about dissecting cellulitis and folliculitis decalvans. She is very well known as a hair expert in the Middle East, and she's published books, and she's a full professor in Morocco, and I thank you for coming.
Thank you so much. It's a great honor for me to share and to present in this session with all the speakers. So I will be speaking about dissecting cellulitis and folliculitis decalvans. Why we choose to speak about both diseases in the same lecture? Because they are both chronic inflammatory scalp diseases. They are both neutrophilic primary cicatricial alopecias. They have chronic relapsing course, and they represent a therapeutic challenge for dermatologists. Look at those pictures. Sometimes clinical diagnosis and differentiation between folliculitis decalvans and dissecting cellulitis can be challenging. The primary lesion of dissecting cellulitis and folliculitis decalvans needs to be recognized in order to differentiate between them. For folliculitis decalvans, of course, we have follicular pustules. For dissecting cellulitis, we have mainly follicular dilatation and plaques of keratin. And of course, it is important for an early diagnosis. So in folliculitis decalvans, we have this follicular pustule due to bacterial colonization. Then we have intense inflammatory response, follicular destruction, and then multiple hairs that become fused, and we call it tufts. For dissecting cellulitis, we have the follicular occlusion and hyperkeratinization, then follicular rupture, abnormal immune response with secondary bacterial colonization, and with deep inflammatory nodules and interconnected sinus tracts. And in both, we have scarring alopecia at the late stage. Management starts from the diagnosis. So clinical findings are both similar in folliculitis decalvans and dissecting cellulitis. It affects young adults, male predominance, and it affects the vertex and the scalp, the occipital area, but can spread to the entire skin of the scalp. Both are chronic inflammations with scarring, and in both diseases we can have itching, burning, and pain, especially in dissecting cellulitis. In folliculitis decalvans, we have pustules, crusts, and tufted hairs. We will see the pictures. And in dissecting cellulitis, we have the coexistence of early follicular lesions with plaques, pustules, and mainly painful abscesses and nodules during sinus tracts. And in both, we will have scarring alopecia, but the particularity of dissecting cellulitis is that the scarring alopecia is irregular and with sometimes hypertrophic scars. An interesting finding in dissecting cellulitis is that in the late stage, we can have this cerebriform appearance, and it could be misdiagnosed as cutis verticis gyrata, and this we call it the positive jacket sign that appear mainly in the dynamic evaluation of the scalp when you compress the scalp between two hands. Trichoscopy correlates with the physiopathology and with histopathology in folliculitis decalvans. As you see here in the picture, the inflammatory infiltrate is around the infundibulum, and in dissecting cellulitis, it is deep. It can arrive until the subcutis. The three patients share similar findings: follicular pustules, crusts, and erythema. This is, of course, patients with folliculitis decalvans. This is trichoscopy. We see yellow and red signs, and this is the summary of the trichoscopy of folliculitis decalvans. Yellow signs with follicular pustules, yellow tubular scaling, and crusts, with red signs, as you see here in the picture, with perifollicular hemorrhages and erythema, and we can have also tufted hairs. And in advanced stage, we will have the scarring with white, milky red areas, lack of follicular openings, tufted hairs, cicatricial white creamy areas, and this interesting starburst epidermal hyperplasia around tufted hairs. So it is important for management to determine the disease activity. You can use this trichoscopy activity scale. And also severity assessment is important. In folliculitis decalvans, we can use the maximum diameter of the largest alopecic patch, or this physician global assessment with mild, moderate, and severe. So we will see patient and we'll try to determine severity. This is a patient with pustules. So normally he's in mild and moderate stage, because in mild stage we don't have the pustules. in that area. The same patient, we don't see the pastels, so we may say that he has a mild disease, but the problem is that he has also involvement of the frontal area and also the body hair involvement.